All right, you guys, we are going to spend the next couple of videos introducing the individual antimicrobial agents that are used systemically. And this could go on forever, but I'm trying to keep it pretty general. Mostly my objective is just to introduce the classes of the drugs and give you some basic information about them. You can do a much deeper dive into this and probably will at some point, but at this juncture we're just going to try to get a little bit familiar with them. So we're going to break these videos down. We'll probably do 5 videos, one for each of the different classes of the antimicrobial agents that we are going to cover. I want to start with a group of drugs called the cell wall synthesis inhibitors. So the cell wall synthesis inhibitors are a group of agents, and I'm going to flip the slide one, and here you can see them, and I'll go back to that slide in a minute. So here are the agents that affect the cell wall. So if you recall in our previous video, we talked a little bit about how these different drugs act, and the cell wall is a big target for these particular drugs. So the cell wall synthesis inhibitors do exactly what they sound like they would do, and they inhibit the structure, the building of the bacterial cell wall. They get in the way of the ability of they get in the way of the peptidoglycan kind of structure, if you will. So basically they get divided into a couple different classes. So here are the big ones. So there's 4 members of a group called the beta-lactam antibiotics. And the reason why they're called the beta-lactam antibiotics is because they're all structurally similar, and they all contain what we refer to as the beta-lactam ring, which I'll show you, and I have a picture of in the previous slide. So the beta-lactam antibiotics are the penicillins, and here's a list of most of the penicillins. The cephalosporins, which have been broken down into first, second, and third and fourth, generation. We'll talk about those next. The Carbapenems and the Monobactams. So these are all structurally similar drugs, being that they all contain the beta-lactam ring. And then we have some other antibiotics that also interferes with the cell wall, but they don't have that beta-lactam ring. And those are bacitracin, vancomycin, and daptomycin. We talked briefly about vancomycin and daptomycin in the very end of our last lecture when I was talking about antibiotic resistance, specifically around MRSA. And then we have this other group of drugs called the beta-lactamase inhibitors. And this has something to do with resistance. So the bacteria have kind of learned how to outsmart the drugs, which as we talked about in the last video. And I use that term outsmart loosely because it's not like a conscious thing. It's just sort of, luck in terms of mutation. But what they do is they produce an enzyme called beta-lactamase, which basically busts apart the wall of the beta-lactam ring, which makes the drug ineffective, essentially. So these drugs here, clavulanic acid, sulbactam, and tazobactam, are oftentimes referred to as the rejuvenators, And what they do is they work in tandem with an antimicrobial agent. They don't have any profound antimicrobial action on their own, but when you combine them with another drug, what these agents are able to do is they're able to inhibit that enzyme, beta-lactamase, that busts apart the ring. So they essentially help the drugs be more effective in a situation where they normally would have lost efficacy. All right, so I'm going to flip back to just talking about the cell wall synthesis inhibitors. So there's our family, the beta-lactam family, and then vancomycin, bacitracin, and daptomycin are referred to as glycopeptides. Their mechanism is to kill bacteria, so they're bactericidal, by preventing the synthesis or the repair of the cell wall. Of course, we know that the cell wall protects the bacteria, right? The bacteria are super concentrated inside, they're hyperosmolar. And if you disrupt that cell wall, then the bacteria will absorb water and they'll explode. So what these drugs do is they bust the cell wall, essentially. That's how they act. They do it in a little more complicated way, but that's good enough for us to know they interfere with the cell wall, and therefore they weaken the cell, and it ultimately lyses. So let's talk about the first group. Oh, here's another picture of this. This is a nice picture. This is the beta-lactam family, only not the glycopeptides. So you see the penicillins, the cephalosporins, the carbapenems, and the monobactams. And you can see some of the different drugs that are in there. You're not going to be responsible for knowing these all by name in this class. You'll probably have to know them some other time, but not now. Now I just want you to kind of know the classes. The natural penicillins are the ones that are basically synthesized from mold, and then these are made synthetically in a lab. All right, so let's talk about penicillin for a minute. So penicillin is a cell wall synthesis inhibitor. Oh, down here at the bottom, here you see the beta-lactam ring right here. This is the beta-lactam ring. So all the drugs in the beta-lactam family are going to have the beta-lactam ring. So penicillins, because they break apart the cell wall, they're going to be considered bactericidal. Almost all cell wall synthesis inhibitors are considered bactericidal. Penicillins inhibit the last step of cell wall synthesis, and they cause the cell to bust apart really quickly. The earlier penicillins were considered to be narrow spectrum, meaning that they weren't effective against a huge number of organisms, but the organisms that they were effective against were pretty much the ones that were really problematic. So that made them a great drug, right? It made them very, very important. This is the first penicillin. It was like 1950s when penicillin hit the market. And they were definitely effective against some of the more troublesome gram-positive and gram-negatives that were causing a lot of issues. So these were really important drugs, and still are to some degree, but there's a ton of resistance to these drugs now. So as they started to make new versions of penicillin after that first the natural penicillins, they started to extend their spectrum some, right? They got there. So when we go from there's some penicillinase resistant organisms, those were still narrow spectrum, mostly gram-positive. But then as we get into the aminopenicillins and the extended spectrum penicillins, we pick up a few gram-negatives also. They have a large therapeutic index, which means you can, and that makes sense if you think about it, because they attack cell walls, and our cells, eukaryotic cells, don't have cell walls, so they don't generally do anything to eukaryotic cells. And as I said a little while ago, resistance is a big deal with penicillin, so that makes these drugs not so effective to us anymore because of this resistance. You can kind of if you look in your book, you have on page 155, you have the different groups of penicillin, and you can see the organisms that they're effective against. And there's a lot of them if you look. There's, the streps, Neisseria, the H flu, E. coli. As we get more and more, as we get higher up in our groups, we kind of extend our spectrum a little bit more. Penicillins have some adverse effects. Like I said, they have a narrow therapeutic window, which means that they're pretty safe, but there's still some adverse effects. The allergic reactions are the big thing to think about with penicillins, and oftentimes these allergic reactions get broken down into 3 types: those that happen immediately, those that are a little accelerated, and then the late symptoms. So the immediate ones are the most severe, and usually if someone's going to have an immediate reaction to penicillin, it's going to happen within about 20 minutes of giving that drug, and it's going to look kind of like a anaphylactic type of an event. So they're going to be nervous and anxious and itching, and they may have some numbness and tingling, probably some wheezing and coughing and choking, potentially fever, edema, those kinds of things, lots of hives. This can lead to hypotension, shock, and those kinds of things, right? This is an immediate hypersensitivity reaction. You guys might remember that immediate hypersensitivity reactions are mediated by the IgE antibodies, and so this happens pretty quick. The accelerated reaction usually happens an hour to about 72 hours after somebody's been administered the drug, and it's mostly going to look like hives. And then the late reaction is the most common with the semi-synthetics. And this is going to appear after 72 hours, up to a couple weeks in some cases. And it's usually going to look like skin rashes. So skin rashes are the big thing. And you can see at the bottom of our slide, we have ampicillin being the most common for the skin rashes. And of course, there's some other things to think about as well with some of the individual penicillins. We're not going to spend a lot of time on these, but you can sort of see this and have it as your own information. So we talked a little bit about these penicillin rejuvenators, right? On that slide, we saw in the beginning clavulanic acid, sulbactam, and tazobactam. So basically, these agents are the beta-lactamase inhibitors, and they're going to be compounded with a penicillin. And they're going, the addition of these inhibitors are going to rejuvenate these penicillins, making them more effective. So basically, remember we said that the beta-lactamase enzyme breaks apart the beta-lactam ring. So the beta-lactamase inhibitor inhibits the beta-lactamase enzyme from breaking apart the ring, and it allows the penicillin to break the cell wall, to decrease the synthesis of the final steps of the cell wall. So it's a tiny bit confusing. The thing to know about these guys is on their own, they don't have any real antimicrobial effects, but when you add them in with the penicillin, they potentiate the action of the penicillin. So here's a picture that kind of illustrates this point. So, excuse me, we have number of viable bacteria here plotted against time. We have a couple things happening. Our control is no drug whatsoever, so you don't give a drug in a person that has a bacterial infection, and you see the number of viable bacteria going up over time, which isn't surprising. You give someone just clavulanic acid on their own, you still see the bacteria going up over time. Amoxicillin on its own, same. Bacteria and levels climbing over time. So this means that this particular bacteria is resistant to amoxicillin. However, if you add amoxicillin plus clavulanic acid, you put them together, then you have a sudden decrease in number of viable bacteria over time. So that's how these rejuvenators work. So they don't do much on their own, but in tandem, they have quite a bit of efficacy. All right. The next type of drug are the cephalosporins. These drugs are classified into generations 1 through 4. It's really kind of hard to learn them all because there's so many of them and they all kind of sound the same if you ask me. As we go from generation 1 through 4, we change our effectiveness against, or we throw in some more agents that are going to be affected by these drugs. The first generation's got a pretty narrow spectrum, very similar to penicillin, and also is susceptible to that same beta-lactamase enzyme. When we get into the second generation, so the second ones are over here, and you can see mostly gram-positives, a couple gram-negatives. Then we get our second generation, not quite as many gram-positives, but we get another gram-negative Neisseria and cocci, and then pick up a couple more gram-negative rods with the second generation. So we've got an increased activity towards some of these gram-negative organisms, and in the second generation, these drugs tend to be quite a bit more stable. In our third generation, we get an even broader spectrum, and this third generation is more resistant to the beta-lactamase enzyme, so not quite as much resistance, at least initially, with the third generation. And then the fourth generation, which is not on our slide there, we've got some gram-positives, gram-negatives, especially Pseudomonas. That one gets picked up, which is a sort of a tricky one. You see that in the third generation too. I didn't say that. And then we also have 1/5 generation, which is going to be pretty good for MRSA, which remember we said MRSA is a tricky one to treat. So one thing to know about them is if someone's sensitive or allergic to penicillin, about 10% of them are also going to be allergic to cephalosporins. So that's something that we want to think about and probably avoid in someone that's highly allergic of a known penicillin allergy. These also can cause some GI disturbances. They can cause some blood disorders. But for the most part, they're going to work a lot like penicillin. Another thing about cephalosporins is some of them have anti-vitamin K effects, so they can cause bleeding, which is good just to know. And I guess that's all we really need to say about the cephalosporins at this point. I think I mentioned, but maybe I didn't, hopefully I did mention that these are effective against Klebsiella. Oftentimes these are the drugs, the cephalosporins are the drugs that are used as prophylactic agents, so they're used before, during, or after surgery to minimize bacterial infections. All right, and you can look in your book, there might be a few more things that we say about the cephalosporins. There's quite a few of them, and there's a chart also on your in your book on page 156 that run you through the first, second, and third, not the fourth and the fifth generation. All right, our next group, oh, here's some of a little chart. I forgot I had it here as well. It's a little bit different than the one in your book, but I added the fifth generation to that one. Okay, so now we have beta-lactam family number 3, the Carbapenems. Carbapenems are imipenem is probably the most well-known. Meropenem is another one. Carbapenems have pretty good coverage of most gram-positives and gram-negatives. They're resistant to beta-lactamase, which is nice. They're good for a whole bunch of stuff. And are more or less similar to penicillin. They cover some of the aerobes and some of the gnarly, pesky anaerobes as well. They're oftentimes administered with another drug called celastin. Helps to get them in there, get them a little bit, make them a little bit more effective. Also effective against Pseudomonas. These drugs are often also used with aminoglycosides to make them a little bit more effective. What else do we need? They all kind of end in penem, P-N-E-M, which is nice. The reason why we use celastin with these drugs is it decreases the kidney excretion of them, so it keeps them around a little bit longer. So for that reason, they're oftentimes used together. Oh, and then at the bottom there, it says it must be given IV or IM. I should have put IM on the list as well. Could be given IV or IM. The last in our beta-lactam family here are the Monobactams. The Monobactams, the one that's given is this one up here is the most commonly given Monobactam. It's a really good drug for aerobic gram-negative bacteria, which it says on there, including Pseudomonas, but it's not effective against gram-positives. It doesn't seem to have the issue with the penicillin allergy, so this is an alternate use for those people with penicillin allergies. You can see they're used to, this particular class of drugs is used to treat septicemia, septic infections, lower respiratory infections, urinary tract infections, intra-abdominal and gynecological infections. We got to watch the liver enzymes with these drugs. And also nausea, vomiting, and rashes are pretty common. I would say that rashes are pretty common with all of our beta-lactam family drugs. Okay, so that's the Monobactams. So finally we have our glycopeptides. Glycopeptides, the examples of glycopeptides are vancomycin, bacitracin, another one that's not on there that I mentioned in the previous slide is daptomycin. That's kind of a newest one with a spectrum of activity very similar to vancomycin. So these drugs are cell wall synthesis inhibitors, just like the other ones, but because they don't have the beta-lactam ring, we don't have to worry about cross-sensitivity. Because these drugs are the ones that are treating MRSA and some of the only drugs effective against methicillin-resistant Staph aureus, we really want to reserve these for hospital-based infections that are resistant to other drugs. Vancomycin is only effective against gram-positive organisms, and it's also really poorly absorbed orally. One thing about vancomycin, which I don't have on there, but I should, is it causes a dose-related ototoxicity, so toxic to the ears, that produces ringing in the ears, high-tone deafness, hearing loss, and maybe possible deafness. So this is a big deal, and you want to remember that about this drug. That might come up somewhere. Bacitracin is only used topically, pardon me. It binds to a lipid carrier that transports the cell wall precursors into the growing cell wall. So it can be classified as a cell wall synthesis inhibitor. Also can cause pretty serious nephrotoxicity, which is why it's only used topically. I think I mentioned already daptomycin is going to have a very similar mechanism to vancomycin. It has a little bit of a different mechanism. It binds to the membrane of the bacteria, and it causes a depolarization of the bacteria. When the loss of the membrane potential is what causes the death of the bacterial cell. So it's not really truly a cell wall synthesis inhibitor, but it inhibits the function of the cell wall. One of the weird, kind of strange side effects of the glycopeptides is something called red man syndrome. So we kind of want to watch out for that. Red man syndrome is a big deal. I'm trying to think if there's anything else I need to tell you about these drugs. And the red man syndrome, as it sounds like I should explain that. Red man syndrome is basically like the whole, it's like a crazy rash, whole skin, everything turns red, and then the skin tends to sort of peel off. So it's definitely kind of a nasty side effect. And then once the skin peels off, it's almost like they've been burned, so they are at increased risk for infection. And you have to remember that they're usually using these drugs because they have severe hospital-based infections, resistant hospital-based infections. So this is kind of not a good thing. And I think I said in my conversation about MRSA that we're starting to see resistance to vancomycin, which is pretty scary. I think that's all I really need to tell you about these. So here's a picture of the vanco spectrum. Okay, so we're going to, this is showing us, we're going to go into the next group, which are the ones that are going to inhibit the protein synthesis. But I'm going to cut this video and I'll start the next one in a minute.